My name is Marnie Kaufman, and I am co-founder and director of the Adenoid Cystic Carcinoma Research Foundation, or ACCRF, and I am incredibly excited to have so many people watching our third webinar. Like many of you, I had to learn about adenoid cystic carcinoma, or ACC, after feeling undiagnosed pain in my neck for over 12 years. Then in 2004, I was diagnosed with a tumor in my parotid gland that had invaded my facial nerve, and that turned out to be ACC. I remember the fear and anxiety that I felt, my husband felt, and my extended family and friends felt to be diagnosed with such a rare cancer. In today's webinar, we want to give you a better understanding of what ACC is and to discuss questions that you might have so that you can best understand and manage your treatment options. To that end, we are so grateful and honored to have Dr. Busse, Dr. Ha, and Dr. Su, who are three of the most compassionate and competent doctors that I know of, sharing their Saturday with us. Next slide, please. After I give some thoughts about my initial diagnosis and treatment, my husband, Jeff, will tell you some quick facts about ACC and ACCRF. Then Dr. Nicole Sparty-Burr, our Director of Research, will introduce our esteemed panelist, and that will be followed by a panel discussion with Dr. Busse, Dr. Ha, Dr. Su, Jeff, and Dr. Sparty-Burr. Finally, I'll share some key takeaways and get some feedback from you all. Next slide, please. I have a few housekeeping issues to go over. First, the questions from the panel are drawn from the registration forms, but feel free to keep adding questions to the chat. We'll be monitoring and recording those questions that we'll try to address if time permits or at a later date. However, we won't address questions relating to any individual patient. Please don't put any personal information like your medical history into the chat, and we ask that you don't copy any information from the chat and distribute it. ACCRF does not provide medical advice, so all treatment decisions should be discussed with an experienced physician in a private setting. Comments in this webinar refer to broad patient groups, not to any individual patients. And finally, this webinar is being recorded and will be available for others to watch. As I mentioned up front, I was officially diagnosed with ACC in 2004. Oh, I forgot to put the next slide up. Thanks. I was officially diagnosed with ACC in 2004 with a lump in my neck and pain in my facial nerve. Like many of you, I had never heard of ACC and didn't know anyone with the cancer. My husband and I had 4 sons under the age of 10, and we were panicked and full of unanswered questions. We were lucky to live in Boston and have access to outstanding medical centers with doctors that had experience with the disease. We were even able to get second opinions at different hospitals, and we eventually had a treatment plan. But to give you a sense of how nervous we were, I begged a local photographer to take our family's first ever professional photo the day before my surgery. You can see the photo on the screen here. To me, it brings back the real fear that we had. Will I survive this surgery and cancer? How disfigured will I be? Can I handle 7 weeks of daily radiation? These are real fears that many of us have to face. And looking at the same picture again can now make me feel profound gratitude. Because on July 25th, 2004, I had surgery to remove my parotid gland and the lowest branch of my facial nerve, along with nerve grafting to improve the functionality of my mouth. This was followed by 7 weeks of radiation treatment. It was not pleasant. And even though I joke with Dr. Busse that radiation is the gift that keeps on giving, I feel so fortunate that this difficult treatment was so successful. In fact, 2 weeks ago, I celebrated 18 years since I finished my treatment. After treatment, we realized that practically no one was researching this cancer, not the American Cancer Society, the National Institutes of Health in the US, nor any other institution anywhere in the world that we could find. So my husband Jeff and I founded ACCRF at the end of 2005 to try to learn more about this rare cancer, how to better treat it, and to support others affected with the disease. What we've learned is that treatment options for ACC vary widely based on a tumor's specific location in the body. While most initial treatment consists of surgery and radiation, there can be a great variation in how surgery and radiation is provided based on each patient's individual needs. We've brought this amazing panel together to discuss some of the most common questions that we hear from patients and their support networks as they try to navigate their treatment options. We hope that you find this information helpful to you and your loved one during this difficult journey. With that said, I would like to introduce Jeff, my much better half, husband, father of our 4 boys, and executive director of the ACCRF.
Thanks, Marnie, for that sweet introduction. Of course, anybody who knows us both knows who really is the better half, and I'll leave it at that. Even though it's been 18 years since Marnie's diagnosis, the intense emotions, that time are so memorable. I'll never forget how our family and friends gathered and supported us during the initial shock and the months of treatments, bringing us meals and taking care of the boys. We'll never be able to thank them enough for that. I also remember that during that time, I may not always have been at my best, butting heads with Marnie's surgeon, just out of concern and outright terror about her treatment plan. So my hope is that this webinar will educate you a bit and perhaps calm you a bit during what I know is a hectic and scary time. Now, many of you listening to this webinar are likely new to ACC, so it makes sense to spend a minute summarizing what we know about cancer. So what is ACC? It's a cancer of secretory glands, typically originating in the head and neck region, usually salivary glands, but it's also found in the breast and mammary glands, in skin and sweat glands, and really elsewhere throughout the body. Now, how rare is ACC? Well, we can't say that ACC patients are 1 in a million, because the data says that about 4 of every million people will be diagnosed each year with ACC, which is quite rare. Who gets ACC? It really can strike anyone, and it's just a matter of bad luck. ACC is not inherited. It isn't passed down within families. It's not associated with smoking, drinking, infection, or ethnicity. And slightly more women than men get ACC. And so what happens to patients who are diagnosed with ACC? Well, nearly half are actually cured by surgery and radiation. Unfortunately, about half of patients will eventually experience distant metastases, usually to the lungs. And because we don't know which half of patients are going to never see the cancer again and which half are going to, it makes sense to have decades-long or lifetime monitoring to make sure that the ACC hasn't come back. Now, if ACC does recur, usually in about 2/3 to 3/4 of patients, those recurrences grow very gradually, over years and decades. Unfortunately, there are some cases that are much more aggressive and do require more, intensive treatment. So that's our summary of the disease. So at ACCRF, our mission is incredibly simple, simple to understand but hard to achieve. We want to accelerate the development of better treatments and a cure for ACC patients, so that patients lead better, longer lives. Our strategy for getting there is by creating a community of researchers following a coordinated plan that is driven by supportive and supported patients like all of you today on this webinar. So ACCRF really sits in the middle of an ecosystem. It's within this research network that, that ACCRF strives to engender collaborations and accelerate the research. First and foremost, are the patients in this network. Nothing can be done in research without patients, without their tumors, without their medical records, without enrolling in trials. Patients are absolutely central to the research endeavor. We also have strong relationships with academic institutions. We've given grants to more than 50 grantees at more than 30 institutions globally, and it really is a global effort spanning Europe, Asia, Australia, the US. Our network really goes all over the world. We also work very closely with public and charitable funders like the National Institutes of Health, where we will co-fund grants or alternate grants to support those academics studying ACC. And lastly, we have close relationships with private industry, the companies that are working with us in our preclinical screening models to find better treatments for ACC. So ACCRF really tries to bring this ecosystem together and to make it operate as efficiently as possible for the benefit of patients. I want to highlight just a few web pages that may be particularly relevant for this group. This group that where we're looking at dealing with primary ACC tumors. We have here a slide with the web address at the top here, which hopefully we'll put into the chat or the Q&A. We may have to put it into the, we'll look in either the chat or the Q&A for it. But the newly diagnosed web page is really appropriate for people who are really coming to ACC for the first time and trying to figure out their treatment plan. A huge part of that treatment plan is finding an experienced physician, someone who's dealt with ACC, understands it, and can really guide your treatment, hopefully over many years. And also, even if the person is not involved in your treatment, it's incredibly important to get second and third opinions to make sure you're comfortable with those plans. And this Find a Physician webpage can help you do that. Now, some patients prefer to focus on their disease just with family and friends and not to keep it narrowly focused. Some patients really want to connect more broadly to get the perspectives and emotional support from other patients. And so on our peer support webpage, we've got links to various groups that can provide that peer support. And my last point is that at the top of any of our web pages, what you'll find is a place where you can sign up for our email updates. And that's really the best way to stay informed about the latest research, about patient events and other resources. So I'd encourage you to sign up for our email updates. So now let's turn to the real purpose of today's webinar, which is to answer your questions about dealing with ACC primary tumors. I'd like to introduce our Director of Research at ACCRF, Dr. Nicole Sparty-Burr, affectionately known as Nikki. Nikki joined ACCRF 6 years ago after many years as a PhD researcher at the Dana-Farber Cancer Institute here in Boston. So I'll turn it over to you.
Thanks, Jeff. I'd also like to welcome you all to the webinar and thank those of you that submitted questions. It seems like that the chat has been disabled, so if you do have questions during the webinar, please enter those using the question and answer button. Panelists, you may now turn on your video and microphones. It's my pleasure to welcome our distinguished panelists today, Dr. Paul Busse, Dr. Patrick Ha, and Dr. Shirley Su. First, I'll list each of the speakers' affiliations and then invite them to share a brief introduction. Dr. Paul Busse is a head and neck radiation oncologist and director of head and neck service at Massachusetts General Hospital. He is also an associate professor at Harvard Medical School, and his clinical interests include IMRT and proton radiation therapy. Dr. Patrick Ha is a professor and chief of head and neck surgical oncology at the University of California, San Francisco, where he also holds the Erwin Mark Jacobs and Joan Klein Jacobs Distinguished Professorship in Head and Neck Surgery. His research interests include understanding the molecular changes that occur in adenoid cystic carcinoma. And Dr. Shirley Su is an associate professor in the Department of Head and Neck Surgery at the University of Texas MD Anderson Cancer Center, where she specializes in surgery of benign and malignant tumors of the sinonasal cavity, nasopharynx, and skull base. Dr. Su also serves as the chair for skull base divisions of the American Head and Neck Society. I want to thank our panelists for joining us today to speak about how to deal with primary ACC tumors. And next, we'd like to invite each of the doctors to introduce themselves and share a little bit about their experience treating ACC patients. Dr. Busse, we'll start with you.
Well, thanks so much for this invitation from you and from the Kaufmans to be involved in this great webinar. I've been in practice for 40 years, and when I finished my residency, I was at the Dana-Farber for 17 years in the Brigham. We ran the head and neck service there, came to Mass General in 2003. So a lot of my experience at those two institutions has been treating people with rare and unusual diseases, because Boston is an epicenter for that. And so I probably have one of the unique clinical experiences for a professional in having treated many, many patients with adenoid cystic carcinoma in different stages and in different locations. So it's been a real privilege to be able to treat these folks and to work with a great group of colleagues, both at the Mass Eye Infirmary and previously at the Farber. And I think the important thing that Jeff alluded to in his preamble was, it's important to have a clinical team. And this is a disease that's not treated by one specialty alone. And we all make our contributions, and it's that collective effort that puts together the most important treatment plan, or the one that has the highest level of success.
Thank you, Dr. Busse. Dr. Ha, why don't you go next?
Great, thanks. And thanks again to the organizers for this. We've known each other for a long time. I forgot that it was 2005, way back when. That's when I was finishing my residency and fellowship that we connected. So, you know, similar to what Dr. Busse was saying, is I think that there's a lot of, you know, uncertainty in this disease. And so, you know, each of us on the care team plays a certain role. And I've always appreciated that about head and neck cancer in general. With adenoid cystic carcinoma, it's even more important that there's confidence in every member of the team, and that there's a level of understanding of not just the disease, but of the patients and their psychology, almost, of, you know, managing this disease and thinking about, you know, is this going to recur, and being able to provide comfort and support if and when that happens. I think from a research standpoint, it's also quite fascinating in terms of the, you know, different aspects of adenoid cystic carcinoma. And so that's what that appealed to me as well as I was graduating, to consider a scientific career in trying to figure out what are the areas that we might be able to capitalize on, or what is unique about ACC, and that we could, you know, try to move forward in the field of treatment. So for this and all these other reasons, I think that it's a very special group of patients, and the disease itself, there's so much unknown. That I feel like we're just at the tip of the iceberg, but that there could be room for quick discoveries, because it is such a rare disease that seems to have such unique characteristics. So we're still searching for those answers.
Thank you, Dr. Ha. Dr. Su?
Thank you so much for having me today. It's a pleasure to be here. So after residency, I did my head and neck fellowship at MD Anderson, and then a second fellowship in skull-based surgery. And my purpose for that was, I really wanted to combine being a head and neck cancer surgeon with the techniques that are associated with skull-based surgery, in particular open endoscopic skull-based surgery. And I've been on faculty at MD Anderson for almost 10 years now, and we're fortunate in that we are a tertiary referral center for rare diseases and recurrent diseases and difficult diseases. So I've been fortunate in having met a lot of patients with tumors of sinus disease and skull-based disease over the last decade. And I've seen, and of those, quite a few are adenoid cystic carcinoma patients. I would say that I do head and neck cancer surgery, and I also do skull-based surgery. And I think that with tumors in the head and neck are unique in the considerations that we give to function, because in the head and neck, there are just so many organs there that can be affected. And I agree with Jeff that this is a group of people who are going to survive for a long time, even though the disease may come back in the lung, that a lot of people can survive many years with that. So function is really critical. Thinking about what someone's survivorship needs are once they're cured, or even before they start treatment, I think that's critical. And in the skull base as well, where you have a tumor in the nasal cavity, is right next to the eye, to the brain, to the hearing apparatus, to the pituitary. We can talk about some of that later. I think there's a lot of functional things that needs to be considered, and it's something that I've been very interested in, and I think that interest really came from working with my patients and being with them for a long time, following them up for a long time, where you become friends and your conversation shifts away from, well, how does my scans look? Has my tumor come back to, how's life going for you? Are you going back to your job? Are you able to see well and drive and all those other things? And so it comes from that interest for function for me really came from my experiences and my relationships with my patients.
Thank you all for those introductions. Now we're going to start the question and answer portion of the webinar. The questions have been divided into 3 sections. First, we'll focus on the initial surgery and postoperative radiation, then on primary tumor location and biopsy, and finally on long-term treatment, post-surgery, and radiation. Questions will be directed to a specific panelist in rotating order, but all panelists should feel free to weigh in on any question after the designated speaker has finished. So the first question is directed to Dr. Haas. How are most of your patients diagnosed? And as a follow-up to that, about what percentage have pain, feel a bump, or find out in some other way, like an incidental finding on a scan?
So I think that most of my patients, and it depends on where the tumor is originating. So if it's originating from a major salivary gland, like the parotid, submandibular, or sublingual glands, those are more likely to be palpable. Although many people aren't used to feeling their neck. So it's not something that they're always aware of until you point it out, and then they're aware that that mass has been there, or maybe has been there for a while. I'd say that about half of the patients actually have some pain or some symptom that develops as a result of that bump. But again, like half of them, they just notice a bump, it's painless, doesn't seem to bother them outwardly. There are some warning signs, pain being one of them, that that there might be something going on. If there's any facial weakness, that does happen from time to time, where people's face, either part or all of it, may develop some palsy or temporary weakness, or even spasm early on, where there's little twitching. Those can sometimes be signs that there's ACC or other type of salivary cancer present. As Jeff alluded to, there are different areas where the tumor may arise. So if it does arise from somewhere deep within the sinuses or skull base, again, they're unlikely to see or feel this, but there may be pain, there may be bleeding, nasal obstruction, something like that. So there's a bit of dependence on where it is. I'd say that from incidental scans, because this is quite rare, only 4 in a million, it's not that common to have ACC in particular show up on an incidental scan, although it can. Sometimes people come with they get in a car accident, they get their spine or their head or something like that, and then you might see the tumor. So that can happen, but I think just the rarity of it means that it's not that common. So again, most of the times it's a bump. It half and half, could be painless or incidental, but they need to be checked out.
Just to add to that a little bit, people tend to think of pain only when there might be involvement of the nerve, but there can also be numbness in an unexplained fashion. Particularly if the tumor arises in the minor salivary glands of the palate, people can, if it tracks along one of the divisions, the second division of the trigeminal nerve, there can be unexplained numbness of the teeth or of the palate, or in this part of the face.
Thank you. Okay, the next question is to Dr. Su. Do all patients get a biopsy before surgery? And when do you prefer a core biopsy or a fine needle aspiration or FNA biopsy?
So everyone should get a biopsy before any sort of treatment. And there are several reasons for that. First of all, you don't want to undergo unnecessary treatment. You want to undergo the correct treatment. You want to make sure that the treatment is tailored for your particular type of disease. So, and then thirdly, once you are treated, you really want that tissue there because there may be a wonderful discovery of a drug later on that could benefit you. So you need that specimen there. It's for your own benefit as well. But we think about biopsies in terms of tiers. What's the easiest one to get to what's the hardest one to get to? How easy is it to get to do a biopsy? So there's a sort of like a step ladder where you choose the easiest one first. And I would say of all the ones you discussed, the fine needle aspirate is the easiest, and that's the most common one we use for lymph nodes, for submandibular glands, for parotid glands. But it's not going to. Usually it's done with an ultrasound. Sometimes it can be just done with palpation. So the technologist feels it and puts a needle in. It does have limitations. With a fine needle aspirate, there's not a lot of tissue. So they can make a generalized diagnosis, but then they find it hard to give you specifics about this tumor, like the grade, for example. Also the fine needle, sometimes when you have a few cells, it can be confused for a different type of tumor. Sometimes, also a salivary gland tumor. In the parotid, it doesn't matter as much because this tumor is going to come out generally, so it's not as much of an issue. Now, the core biopsy is better because in terms of getting more tissue, more solid diagnosis, more tissue to do different types of stains and biomarker testing that may drive treatment down the track. And it's, so for example, in our MDN, one of the trials that we have is the Notch inhibitor AOA 101 trial. And for that, we need a core biopsy to stain for the tumor, and you also have more tissue for analysis. A core biopsy is also good if the tissue, the tumor is located in an area that a fine needle cannot get to, and usually those are done by CT guided biopsies. And then the third one is an open biopsy. In the salivary glands, easily accessible places, we don't tend to do open biopsies because there's a risk that the tumor can seed along the skin and make future surgery and treatment more difficult. But in spaces like the nasal cavity, in the sinus, where I can be in clinic with you, I can look at it and it's right there. I can take a biopsy. It's not going through skin or lining where I could see it and potentially make this treatment more difficult. That's an area where you need an open biopsy. And in the sinuses, because it doesn't go to the lymph nodes as much, then usually the indication requires that you do an open biopsy.
I might just add that I'm not a pathologist, and I think none of us on the panel are, but I think there's a preference as well for the pathologists. There's certain pathologists who are trained in cytopathology in particular, and they may find unique characteristics on the biopsy that they favor looking at, whereas others, may need that core of tissue in order to make a better diagnosis. So I believe some of that is really up to the pathologist. The only one thing I mention is that if a core biopsy is done, from a surgical standpoint, it can sometimes induce a little bit more of an inflammatory response. But I think, as Dr. Su said, the most important thing is getting the diagnosis and getting the right treatment. So to some extent, whether it's a core or a fine needle biopsy, the main thing is you want to give the tissue that's appropriate for the pathologist to interpret.
Thank you. Okay, the next question is to Dr. Ha. I was just diagnosed with ACC after a biopsy with my local ENT oncologist. What happens next? What questions should I ask my surgeon?
Well, as we just talked about, the biopsy, I think, is the most important. And in terms of framing this discussion, there can be some uncertainty in the biopsy. So I think it's often good to have that re-reviewed. And, we talked about the idea of second opinions. I think for the pathology, it can sometimes be hard to make this diagnosis simply on a fine needle biopsy. So you want to understand what is a certainty with which they think that's true. This is where sometimes the molecular markers or, understanding that can really nail the diagnosis. I think then with all procedures, you would want to understand the surgeon's experience with this disease and or salivary tumors in general, and to really understand the game plan. So when they get in there, what are the decisions they have to make? And I think there's a few that come to mind that are important. One is the extent of parotidectomy, or depending on where it is, management of nerves that are in that area. Are they going to tend to try to save them, or If they're entwined, what happens to that? And then there's a risk of potentially neck node involvement. Has that been examined? And what's their game plan if they should find something, or if they don't, and to understand sort of all the aspects of that surgery. I think those are important questions to start with.
Okay, the next question is to Dr. Su. My surgeon was unable to get clear margins. How does this change my treatment plan? Am I more likely to experience local recurrence and or distant metastasis?
Right. So I think that in general, the principles of cancer surgery is that where possible, you take out all the cancer that you can see, and ideally you take it out with a cuff of normal tissue. We consider 5 mm cuff of normal tissue around a tumor to be ideal, great bigger if possible. But of course, there are times when you can't get that, and you may be 1 mm. For example, if your tumor is in the salivary gland here in the parotid and it's right on the facial nerve, and you can just peel that tumor off the nerve. But if you were trying to take 5 mm, you'll cut into the nerve. Well, there's no need to do that. But in general, we would like to see negative resection margins of some kind, because we know that overall, across multiple tumor types, that's what confers better survival. That's what decreases the chance of the tumor coming back in the long term, both in the site of the tumor and to reduce the chance of it coming back in a different site, either in the lymph node or further outside of the body in the head and neck region. So when we have tumor that's left behind, I tend to think of it in terms of two factors. Is the tumor left behind because the tumor itself has not been removed in its entirety? And this may be that the tumor is against somewhere where it is difficult to take out, for example, the carotid artery in skull-base surgery, or it's right on the optic nerve to the eye, for example. Or is it somewhere that is next to a structure that could be taken out, but it's very morbid? That's another consideration. Or was it left behind for some other reason? And then the other consideration is there a positive margin? We call a positive margin because tumor is traveling along a nerve. So perineural invasion, where the tumor travels along a nerve, it occurs in about 10 to 20% of head and neck tumors. But for adenoid cystic carcinoma, it's about 40, 50%. So actually the majority, we tend to think that adenoid cystic carcinoma, the majority of patients will have some perineural invasion. And for perineural invasion, the data on whether you get a negative margin along the nerve is kind of a little bit mixed. I describe it as a freeway. If you have a prison breakout, you can cordon off the area, but when a tumor jumps on the nerve, that nerve becomes a freeway for those inmates to go north towards the brain or south down into a distant site. And classically for us, we like to clean out as much of the nerve as possible, but it's not always possible. And if in those situations, if you get a positive margin on a nerve, please don't be alarmed, because that's where we think that radiation plays a role here to clean out that nerve to areas that we cannot chase.
As a follow-up to that, so you talked a little bit about perineural invasion, but what about tumors that have areas of solid histology, or if a patient finds through genetic testing that they have a activating notch mutation?
Yes. The principle, as we talked about it with surgery, resection, and getting negative resection margins, applies to multiple diseases. And that holds for solid pathology or notch positive. You really, regardless of how low grade or high grade or how aggressive the tumor behaves, we should be aiming for, and we certainly do aim for, getting all the cancer out. I think what you're asking, the question you're posing with the solid pathology and the notch positive, is how do they influence the ability to take it out? Well, solid pathology, adenoid cystic and notch positive tumors are both known to be more aggressive, and they tend to present when the tumor is bigger, and more involving more of the surrounding tissues, and makes it a little bit harder to take the tumor out in its entirety. So more advanced disease, but we would still aim where possible to take out all of the tumor. I've kind of alluded to the things that we absolutely cannot touch. We cannot take out the carotid artery. If the tumors are wrapped around it, we cannot take that out. We don't want to take out the optic nerve. It's not useful. And then there are structures we talked about that are nice to keep, such as the eye, but sometimes may be taken to clear a negative resection margin. And I think if you're in that situation, it's really important to have a solid discussion with your surgeon. Well, what can you take out? You know, and if you did take this out, what's my function going to be like? And that's a very personal decision.
Thank you. Okay. The next question is to Dr. Busse. How important is postoperative radiation for decreasing the risk of recurrence? And does it improve survival in ACC? As a follow-up to that, are there any cases when you wouldn't recommend it?
Well, the first part is fairly straightforward. The answer is yes, it is important. And I have a hard time thinking of a case of where it might not come into play. There really are no randomized trials for this, like there are for other head and neck cancers, just because of so many different variables or variations as to how ACC can present and the different locations, the different manifestations of disease. But what we do know is looking at large experiences from institutions that see a lot of these cases, is that if we just look at who does well, and seems to be always the patients that have had both adequate surgery and radiation therapy to follow. Now, a lot of this comes in following, it's relevant to the last few questions and how things were explained by Dr. Su, that the surgeon does the bulk of the heavy lifting for this disease, unless the tumor is unresectable. And as we always like to get tumor out with an adequate margin, but as you move from the clavicles north, the real estate gets pricier. And so you really don't want Dr. Su or Dr. Ha to take out any more than they have to, but enough that it's an adequate resection. So many times with adenoid cystic, regardless of the original location, whether it's in the major salivary glands or minor salivary gland, there is always some issue of a tight margin, whether it's on a nerve, whether it is the radial extent of the resection, because that's just the nature of the problem. And that's where radiation comes in, because where radiation is not the best approach for gross disease, it's an excellent approach for treating extensive microscopic disease. And that could be tumor extending more proximally along a cranial nerve or beyond the scope of the initial resection, or following lymph nodes into the neck. I'm going to double back on a couple of questions that were asked before and about what type of a biopsy that you need to obtain. And in general, the pathologist wants as much as possible to make a determination. If the tumor is going to be resected, I think an FNA is fine, just to make sure that this is a tumor that's going to be removed and not a benign tumor, say, of the parotid gland. But if it's unresectable, then we really want more information, because we'd like to know if this is a solid type, because that could have an impact on the design of the radiation fields because of the higher incidence of lymphatic involvement, that we would not treat lymphatics if it was the other subtype. So we really need to know that information. And also, one of the previous questions about the initial diagnosis, you really need to have adequate staging information. And what that means is you need a high quality MRI of the face and the neck, particularly of the skull base, to make sure that if there's any obvious involvement of a cranial nerve, which can affect how we approach this. And also to have a chest CT to make sure there's metastatic disease in the lungs. And you need that before we do anything else, whether it's surgery or moving on to radiation.
Thank you so much for going back to give your insight on a couple of those other questions, especially from solid and how that would affect planning for radiation. Another question to you, Dr. Busse. How do I know which type of radiation is best for treating my tumor? We get lots of questions about IMRT versus proton versus carbon ion versus neutron therapy. Are there specific clinical features of the primary tumor that should push me to advocate for one type of radiation over another?
Yeah, okay, so let me pick off the easy one first. Neutron radiation, there was some interest, particularly at the University of Washington, George Larimore, with neutron radiation, and that the idea was that there was a unique RBE, or radiobiological equivalent of that these tumors are more sensitive than other tumors. I don't agree with that, but I think that they have a selective group of patients where they've done well, but the problem with neutrons is that the normal tissue also experiences this high LET radiation, and that's associated with a lot of long-term side effects. So I've seen patients that were treated from Washington first and have come back to see me back in Boston, and they have a lot of side effects. So that's not the treatment of choice. Carbon ions, if you want to travel to Heidelberg or Japan, there are options, but there's only one facility that's under construction in the United States at the University of Florida. That also has radiobiologically some of the dense ionizations that the radiation produces with a charged particle like carbon compared to protons can put more radiation into the tumor and less in the normal tissue. Again, largely these are theoretical advantages and have to do with the targeting of the carbon. It's extremely expensive, and I think there are other avenues to achieve the same results using other things in the United States. Now, protons have really had a resurgence, not a resurgence, but they've grown in their use and availability. When I started my residency in 1983, we were probably the only place that was using protons for head and neck cancers, and even then it was unusual. But we always felt that it would order some advantages. But a couple of things have happened since then. If protons were say here and standard radiation down here 20 years ago, the advances of standard radiation, both in terms of the capabilities of the equipment and the software to deliver that therapy, has brought it up almost to parity with protons. And there are certain, I describe protons as a slightly sharper scalpel, and it's not uniformly better for every person. And because you have adenoid cystic does not mean you need to have proton radiation, even if there's involvement of the facial nerve. Each case is different. And what we've done is we've run comparative analyses between an IMRT based program of radiation and the current standard for proton radiation. And I've actually had some instances where the IMRT produces a better plan. So it's very individualized. Places like the Anderson that have a big experience with proton radiation, it could be the right thing, but so much of it is depending upon who does the plan. I mean, radiation is like surgery because it's operator dependent. It's not just the equipment. It's the experience of the person that designs the plan and weighing the different factors of the dose to normal tissue and to the dose necessary to treat the tumor as to which one's the best for your situation. So, you don't need to travel that far for a unique type of radiation. It's worth traveling to find someone that has done this before.
Thank you. Okay, all right, we're going to move to the next section on primary tumor location or biology.
Yeah,
Jeff's going
so
to answer that.
I'll be asking the questions, but before I do that, I just want to say how incredibly valuable that commentary from Dr. Busse is, in that you've had experience with both proton and sit in a place where you can really give fabulous perspective, whereas you're not biased towards one or the other, but really, that answer was absolutely fabulous. A lot of patients talk about these issues, and it's great to get your perspective on that. So thank you. So now, we're moving to questions related to tumor location or biology. The next question is for Dr. Su. I have ACC invading my facial nerve, and my surgeon recommends surgery to remove the tumor and to follow the nerve to get clear margins. What reconstruction options do I have to avoid permanent loss of nerve function?
Right. So I think what you're saying is the tumor is in the nerve itself, and the nerve has been taken out. Is that, am I interpreting it that way? Right. And I think just before I dive into that, I would say that there is, if the tumor is on the nerve and close to it, but the nerve is functioning, overall, we really try and save the nerve as much as possible. And then we use radiation to clear out the rest of the microscopic disease that's left on the nerve. That's in general being our principle. But where you absolutely have to take the nerve, it's 360 encasement, or the nerve is not functioning in the first place, then there are several things you can do. So at the time of surgery, if we know that ahead of time, we would talk to you about, well, we're going to try and reconnect the nerve in some way. If there is only a very short segment that's taken out or not working, involved by tumor, we'll try and connect those nerves together and stitch them together. And that has a reasonable chance that the facial nerve comes back. It won't be perfect. We generally say there's going to be at least 50% function approximately. That could take 6 to 12 months. So it does take a little bit of time, and it's not perfect. If the nerve segment taken out is so wide that we cannot connect it, we can usually put a nerve cable grafting. So taking a piece of nerve that's unaffected from somewhere else in the neck or in the leg and connecting that. The other thing that we can sometimes do, which is using a nerve transfer. So, for example, using the nerve from down in the neck that supplies motor to the tongue and putting it up into the face to help with in that process. That has its advantages and disadvantages. If you're taking some branches from the nerve to the tongue, that may affect the tongue. And you kind of have to go through a period of physical therapy. How do I make my face work when the nerve that goes to it actually supplies the tongue? So it's almost like training to brush your teeth with your left hand. And we have physical therapists who can do that, but it is a process. It does take a little time to recover. Otherwise, there are things you can do that does not involve this nerve transfer process. So for example, we know that somebody's nerve is being cut and it's going to be a little while before the nerve function comes back. Sometimes we'll put a little gold weight in the eye or tuck the eyelid up a little more at the time. Sometimes if we know that the nerve is not coming back and it's been 6 to 12 months afterwards, we still look at those options, putting a gold weight or maybe picking up the corner of the lip with a fascial sling. The plastic surgeons do that a lot, and some of my reconstructive colleagues do that. And then finally, you can also transfer muscles from different parts of the head or use a free flap muscle transfer, which is when you take nerve and muscle from another part of the body and connect it up to the neck, and then use that nerve that's on, say, for example, leg muscle, and connect that into the face. Again, all those things have the pros and cons. They need to be individualized, and a lot of these things do need a period of rehab to make them maximally optimal.
If I can just add a little, I think depending on the circumstance, sometimes it's anticipated, where the nerve is out and we have a game plan of, that we're going to go in and have to sacrifice, the additional branches of the nerve. And then there's times when it's maybe unexpected, where the nerve is functioning fine, but you get in there and it's actually wrapped, it looks purple, and you think, this is grossly involved, I'm going to have to take that. I think that often when it's anticipated or close to anticipated, either based on a scan or something like that, having that team, these procedures Dr. Su is talking about, many of the more complicated ones, we often have a facial nerve team, which is usually a facial plastics team, who specialize in this. So doing that at the same time, I think offers some advantages because the anatomy then is, well laid out. We've dissected all the branches, and then you can see what's left, and then there's an opportunity to do something about it before letting all the scar tissue settle in. So there's a lot of tricks that they can employ now that can lead someone to have, it's not going to be normal, but much improved function if these things are done at the time of surgery. And I think then the chance of recovering from that is quicker. And then it also, because we're often going to be radiating people after that, if the radiation happens and then one needs to go back in to try to do something, that becomes additionally difficult just from the scar tissue and inflammation.
Thank you. All right, we have the next question for Dr. Ha. If I have ACC of the palate, should I get a free flap or an obturator? And in which cases is one better than the other?
That's a pretty complicated question, actually. So some of this has to do with a personal preference, and some of it I think has to do with just the anatomy. So there are times, so just to be clear, an obturator is basically like a retainer for those of us who had braces as a child, a piece of plastic that can separate the mouth from the nose and the sinuses. That it's a little bit more than a retainer, so it's more like a denture that has a mound of silicone or a plug that will then clearly separate and create a watertight seal, an airtight seal between the nose and mouth, so you can talk and you can swallow. If you think about just the kind of carpentry of that, it has to have enough tissue residual to rest on it. So either from the remaining palate, if there's enough of a bridge, or the teeth that are there that you can clip onto to provide support. Sometimes they'll fashion implants that go up even to the cheek muscles or to the cheekbone to create a structure of titanium implants so that prosthesis or obturator can be stabilized. So there's some limitation there in terms of what is existing, that maybe an obturator is not even feasible because it won't seat properly and create a good enough seal. There's also then the soft palate is another area to think about, because the palate, the hard palate, the bone doesn't have that much sensation once it's removed, like you wouldn't necessarily notice it. But with the soft palate, that's a dynamic area. And if you think about the soft palate, it's supposed to move to close the back of the throat so that when you talk, the air and sound comes through your mouth. And when you swallow, that it flips back again so it doesn't come out your nose. So given that it's dynamic, to try to replace, if that needs to be sacrificed during the surgery, that's a little bit tricky of a place to rely on a piece of plastic. Some patients have a very prominent gag reflex. So if you try to put that plastic and inch it backwards a little bit farther, then there's like a kind of a tipping point at which it gags them too much, or the benefit is not really perceived. Then there's kind of the intellectual side, where some people just don't want to have this thing they take in and out. They'd rather just have a solid, roof of the mouth. And just that thought of that becomes a little bit unappealing. So my general approach in counseling people is that if an obturator is feasible, I actually prefer starting with that, because I feel like during the radiation therapy and things like that, you can have this appliance. It's a little bit more straightforward. It can get you to radiation a little bit quicker. The other sort of more complicated thing to consider is that sometimes on the reconstruction, they'll actually use bone, either fibula or from the hip or from the shoulder, to try to replace that, with the thought that you can try to have implants, dental implants in there, so that it can create a more natural scaffold. One of the issues is that if that bone is placed first and it's radiated, then it could potentially weaken the bone a bit. So again, I feel starting with an obturator, going through radiation, and then secondarily coming back if one wanted to have bone replaced, or if the feeling is that the obturator is not successful, you can always reconstruct secondarily. So those are things that we talk about. It's a long discussion. And I think there's some room for individuality and some room for, what's feasible.
Yeah, I just want to add to that. This is one of the discussions that we sometimes have in our own tumor board, and not just with adenoid cystic, with any tumor involving the hard palate, that there's some thought about reconstructing, but our speech and language pathologists are very, very insistent that people do better with an obturator function in terms of functionality. So that's how we tend to approach it here.
Just one other comment to that. It is actually easier to monitor someone for disease recurrence if they have an obturator,
Right.
because you can literally just take it out and you can look inside there and visually see if there's anything on the surface. So you're a little less reliant on scans, whereas if it's been reconstructed, you're pretty much completely reliant on scans for surveillance.
I would also add that it's not one or other. If you have a free flap reconstruction, it separates your mouth from your nose, and that means you can have and then on top of that, you can put an obturator in to maximize the function. If a free flap is a little, for example, a little high and it needs a little bit of extra bulk, or you want to put an obturator on the top to add some teeth, that can also be done. And you may still have the benefit of the free flap in that you can talk in the middle of the night without having to worry about, well, I forgot to put my obturator in. So I think it's a very individualized decision, and it's really up to the individual and whether they want to go through surgery for a free flap versus just have an obturator. But what's the convenience side of it long term as well?
Thank you for all those very helpful comments. Next question is for Dr. Su. How does ACC with skull base invasion differ from other head and neck sites in terms of treatment approach? What should I anticipate as far as prognosis and quality of life? In a related question, how important is it to seek one of the skull base centers for this type of problem?
So I guess there's three parts to this question. The first part is, how does adenocystic tumors or skull base invasion differ from other head and neck sites in terms of treatment approach? So I'm going to answer it in terms of the adenocystic carcinoma is in the nose and is affecting the skull base, because you can have adenocystic carcinoma in the parotid or the submandibular gland, and it can still travel into the skull base. So I'm just going to kind of not put that aside for the moment, just talk about the tumors in the nose and it goes into the skull base. Well, because of its location, and we talked about the value of the real estate in this area, and it's you really have to think carefully about the surrounding structures. It's right next to the eye, it's right next to the brain, it's right next to the pituitary gland, and so it's right next to the internal carotid artery that supplies blood supply to your brain. So it does pose challenges in terms of how much you can take out. If the real estate was not that generous in the parotid gland, it's even less generous in the skull base. So it makes it harder to take the tumor out and get a negative resection margin. And a lot of times it can still be done, but it is more difficult. And that goes across everything. It goes across into radiation therapy as well. It poses challenges for Dr. Busse and your radiation oncologist as much as it does for the surgeon involved. And overall, though, I think we can still have very high survival. In our MD Anderson series of 160 patients with sinonasal adenocystic carcinoma, our 5-year overall survival was, I think, about 67%. So that's still a very reasonable survival rate. It's obviously not as, it can be higher in the parotid or the submandibular gland, but it's still a very reasonable survival rate, especially if you can get all the cancer out. And then we go into the next question of quality of life. So I think about it in terms of the structures that are in that area. I have a study ongoing where we prospectively enroll everyone, and we put them through very rigorous testing of the eye, the hearing, the balance, the speech throughout this process, is because over the years I've observed that a lot of patients, well, we know that a percentage of patients will have problems with their pituitary gland. But in fact, when I did the study, I found that about 40 or 50% will have pituitary hormone abnormalities, and about 20% will have long-term pituitary hormone issues that can very easily be replaced. So you can give them a hormone replacement, and all of a sudden they feel a lot better. They're not as tight. So I think everyone should get that tested. I think everyone should have an eye test at baseline and have a discussion with ophthalmologists about what does it mean to have radiation to your eye, because there are some patients are going to have eye complications such as cataracts or nerve scar tissue formation in that area. And some of those may be preventable if you catch it early, and the ophthalmologist can do treatments such as hyperbaric oxygen or fasting injections. I get everyone to have a hearing test at baseline, and then afterwards as well to monitor that. And I discuss with them, hey, there is a chance that because of the radiation fields or if you have chemotherapy, it may affect your hearing. So please be aware of that. We can start talking about that and having strategies to deal with that early on. I think the other area that I like to talk to patients about is radiation and this combination of radiation and surgery on their jaw, because when you take out some of the muscles that are behind the maxilla, those muscles control how you're balancing your jaw and how you chew. So that I do see patients who have the jaw deviate a lot, and they have a crossbite after several years, and that can be prevented early if you put in a dental prosthesis to retainer at night. And in addition to that, ways of having our dental oncologists help them deal with potential issues with teeth that's related from the radiation alone or from dry mouth afterwards. So there are a lot of things we can talk about here. I've just touched on a few of them, but I think that there are some side effects that are inevitable trade-offs for getting cure of cancer. But I think that there are things we can do ahead of time, preemptively, and also later on to help manage that. And the quality of life can be very, very good in spite of all of those things if they're managed well. And I think the third question is, how important is it to seek opinion from one of the skull-based centers for this type of problem? I agree with Dr. Busse in that when I make a referral to a radiation oncologist, I'm not referring to the proton or the IMRT machine. I'm referring to that person who has the experience and the knowledge and the aptitude and takes care of the radiation planning. And I feel it's the same for every type of cancer. When you see a head and neck surgeon, you want to be comfortable with them, and you want them to be comfortable with what they're doing. They've dealt with this, they know the disease, they've seen it many, many times. It's the same with any procedure, any surgery at any location, or any treatment for that matter. Same with chemotherapy. How often has this medical oncologist treated this type of disease? Do they know about the trials that are going on and can refer you? So I think that experience does help, and it really is up to you as a individual and the person who's treating you to figure out what their comfort level is and what your comfort level is with them.
Thank you so much. Thank you so much, Dr. Su.
And I would also say, sorry, I would just also add
Okay.
that it's not, I really feel that it's a team approach for any of these treatments. So when you see a surgeon, it's also worth saying, well, who would you like to refer me to? I don't think that in cancer treatment, the surgeon should be able to do all the treatment. Really rely on the team, the medical oncologist and the radiation oncologist, the ophthalmologist, the dental oncologist, or the facial plastic surgeon. It's a team effort. So be comfortable with the team that you have, not just the individual as well.
I think that's definitely the take home note. So we're just we're hitting the hour mark, and we want to be respectful of everybody's time. So maybe we can ask one more question to the group, looking ahead to post-surgery radiation. How do you follow your patients? How often should they be scanned? And then if there is a recurrence, very quickly talking about how surgery or radiation could go back in to treat a local recurrence.
Are you throwing that out for anybody?
Yeah, sure.
Okay, so my approach is I like to get my first set of scans roughly 2 months after the treatment is completed, because that allows for all the surgical and radiation side effects to subside, and I don't want false positive to show up in the scan. And so typically I'll get an MRI of the head, skull base, neck, as indicated, as well as a chest CT to start. And then depending upon if we see anything in the chest, then we would get either a 3-month or 6-month chest CT, sometimes without contrast, because we're just looking for the lung itself. But then on average, I'll get an MRI of the head and neck every 6 months, chest CT in a year for several years. And one of the things that we have to bear in mind is that this is a disease that can show up late for recurrences, even though it's a rare event. So we have to be diligent with this monitoring. And occasionally, I hate to say this, but we're getting some pushback from insurance companies and some external review organizations about allowing these subsequent studies.
Yeah, I'll just point out that I just helped share the ASCO guidelines for the salivary tumor portion. And there actually are not very good studies on the utility of the timing and the timing of scans. But I agree with Dr. Busse that I feel that once we're sort of in the stable section, so perhaps maybe after 3 or 4 years, that chest CT is probably the most useful. But getting an MRI perhaps annually or something like that makes sense. The idea being that if you can find something smaller, perhaps you have more options for either, surgery, reirradiation, or things like that to try to stunt it. But it's a really tricky question. So I'm sure that many people have different algorithms for how they're, managing this. And sometimes it is, unfortunately, an insurance question that if they won't approve the MRI, that, we can defer it for another 3 months. But generally speaking, they like annual scans don't seem to have a problem with.
Thank you all so much. Unfortunately, we're past time, and I want to apologize for that. But I've got to say, there are so few times where we get so much expertise, available to answer these questions that I didn't want to stop you all. And we may have to invite you back to answer the rest of the questions sometime. But we also want to be cognizant of not overstaying our welcome. But again, our deep appreciation for giving part of your weekend to us, but more importantly, we are so appreciative of all the guidance and perspective you've given to so many ACC patients throughout their very difficult journeys. So, thank you all so much for your support and your focus. It's enormously appreciated. So with
Thank
that,
you so much.
we're going to thank you all. You can turn off your cameras, and now I'm going to switch over to Marnie to let her wrap up the webinar.
So I just have to say, wow. I mean, listening to Drs. Busse, Ha, and Su makes me so grateful that these brilliant and thoughtful clinicians are so focused on researching ACC and treating ACC patients. I think we can all agree that we are so incredibly lucky. I also want to reiterate a few points that we want you to remember as you move forward with your new diagnosis. So 1, please review the steps on the ACCRF newly diagnosed webpage. Then find a good physician or get a second or a third opinion until you feel comfortable with your treatment plan. Connect with other patients and caregivers for emotional support if that is helpful to you. And you can check out ACCRF's peer support webpage for options. We'd also love it if you signed up for ACCRF email updates just to stay informed with what's going on. And I want you to remember that there is no right way forward. Only you can decide what is best for you. And a big one is don't assume the worst. So my hope for every patient watching this today or in the future understands that ACC is a treatable disease. In 6 months, the large majority of you will have completed treatment and will be able to start to put ACC in your rear view mirror as an inconvenient bump in the road. This doesn't mean that ACC can be completely forgotten, but it does mean that over half of ACC patients will not have recurrences or metastases. I consider myself incredibly lucky to be in that category right now, but I continue to be watchful and have regular scans and follow-ups with my treatment team. As a very wise man named Dr. Paul Busse said to me 18 years ago when I asked for an optimistic prognosis, he replied, "My hope is that you lead a long and full life and are not too inconvenienced by ACC. His hope for me is my hope for you. because you have got this. You can do this. Next slide. Just we want to make sure that these webinars are about education and hope, and we want to make sure we're giving you all the information you need to make knowledgeable treatment decisions and enjoy your lives. We truly value feedback and would love for you to tell us one thing that worked well, what can be improved, like having the chat open and other topics you'd like us to cover in the future. So you could add comments in the Q&A section that we'll get. And you can email us at any time at info@accrf.org. To wrap up, a huge thanks to Drs. Busse, Ha, and Su for spending time with us today. We've learned so much from you all, and you give us more hope for our futures. We're going to post this recording on our website, and we look forward to keeping the discussions going. So I hope everyone enjoys the rest of their day or evening, depending on where you're located. Take care.